Okay, welcome to the Demonstrating Implementation Excellence stream at SNOMED City Expo 2025. Thank you, IQVIA, for sponsoring this stream. My name is Alejandro López Osornio. I'm a Senior Implementation Advisor in SNOMED International. I'll be your moderator for today's session. We'll address all questions at the end of the presentation. For our online audience, please use the QA button to submit your question to the presenter. For those attending in person, feel free to use the microphone provided in the room when the time comes. There are 2 seats in this front row, and there's 1 seat, I think, on the left. So there are 2 seats here. We have a full room. It's my pleasure now to introduce Pim Volkert from DHD, who will be presenting over 10 years of experience implementing SNOMED in Dutch hospitals, observation and insights. Pim, over to you.
Thank you. Welcome and good afternoon to this session just before lunch. Hope you're not too hungry. Let's start. 10 years experience of implementing SNOMED in the hospitals. My name is Pim Volkert. I'm Strategic Advisor with DHD. And DHD stands for Dutch Hospital Data. This image is the building where we are residing, and there's a lot of other organizations in that building dealing with healthcare and healthcare data, and we were one of them. So this afternoon I will talk about a short introduction about DHD, and then we talk about what we do. Sung-Wook, he will introduce later, but he will talk about the thesauri, what's happening in the thesauri we use, and then we talk about the challenges and the work in progress to make it even better. Just one slide about DHD, Dutch Hospital Data. We are a not-for-profit organization for hospitals, by hospitals. In our board, we have the general hospitals, we have the university medical centers, and the Federation of Medical Specialists. So they are guiding us in the direction, and the hospitals pay for our work. That's how it is. We are over 100 people. We don't fit in the building anymore, so we work a lot from home. If we talk about what we do, I like to show this image. Perhaps you have seen this before. It's a learning health system, and in the center is the medical record. And it's not by accident it has the SNOMED color blue, because I strongly believe that the medical record is the core of a learning healthcare system. And from that, you get the billing, you get data for research, quality registries should be filled, benchmarking in data platforms. And then at the bottom, you see the green ones, AI, user interfaces, which will improve more and more using natural language processing. And if we look at the national activities in the Netherlands, that's not all the activities we have, but if you see the loops, and the bigger the loop, the less people are interested to do good recording. The shorter the loop, people are more enthusiastic to do proper work. So one of the loops is transfer information from one hospital to another or to a GP. We have had a national program called VIP, VIPP, and there's also a law Vegas, and that encourages people to exchange data. And SNOMED is in the core of that movement. And European health data space, of course, with the primary use of data, it sits there. What do you have on Health RI, health research infrastructure? It's a national program getting data out of the system and make it available for research, policy, and innovation. And probably it will end up the functionalities in the HDPNL, health data, everybody. Yeah, thank you, Herco. And we are working on harmonization of all kinds of quality registries. Probably in every country, there are a lot of quality registries, and they have their own data sets, definitions. So how can we harmonize them? That's why we're working on. And it should be fed by the medical records. And AE scribes, who's implementing AE scribe in this audience? Any hospitals? yeah, few. Quite hot topic. We'll come to that later, what we're doing there. And there's a lot of AI programs going on, bigger ones, smaller ones. A lot of hospitals are testing, piloting, a lot of vendors, and looking very promising. But I don't know if you were there at the keynote, but it made clear that SNOMED is in the core of it. What do? We have links with billing. Sung-Wook will explain it later what the link is between SNOMED and the billing system we have. We have the DBC billing. International vendors call it the Dutch billing crap. And I think it is. Nobody from NZA here. Okay. Yeah, with our data, because we have a huge data set, as Sung-Wook will also talk about it, like with, what was it, 3.8 billion with 9 zeros transactions in there. Over 8 million patients, we manage that. So we feed the quality registers with it, and we do also benchmarking. So these are all kind of activities we have at DHD. But we we also busy with AI scripts. But now we talk about the implementation of SNOMED, and we use an interface terminologies for it, the diagnosis, and the procedures thesaurus. And so we will explain everything about that now.
Thank you. Thank you. I hope it has enough juice already, so it won't quit on me during the presentation. Okay. Now we have two standards. We made this. Was mandated by our board to make two standards for documentation of diagnosis and procedures. So we call it the diagnosis thesaurus and the verrichtingen thesaurus. And it uses clinical interface terminology for point of care documentation in the EHRs. As for primary use in healthcare by clinicians and for multiple secondary use cases. This is a schematic representation of the diagnosis thesaurus. It is based on SNOMED CT. The thesaurus consists of interface terms that are familiar and intuitive, recognizable for healthcare clinicians, professionals, and they are intended to support the structured and discrete documentation of diagnosis. Each interface term is mapped to multiple standards that is used for secondary processes, such as billing, but also for registries like the Rare Disease Registry, the ORFA, for the ORFA codes. We have Apache codes for intensive care units, and also ICD-10, DSM-5, etc. We for the diagnosis, the terms are grouped by specialties. And if specialties use of want to document the same diagnosis, then those terms are available for those specialties. The billing codes can be delivered to the Dutch declaration information system, and for registries, and also our LBZ, that's the national database of the hospital data, and consists of medical and financial information. Now, the procedures thesaurus consists of also interface terms. It also contains procedures, and also based on SNOMED and categorized by specialties. and it's mapped to different codes as well. The billing codes from the Dutch billing prep system, and also consilium codes for surgical residents in trainee residents, so they can register, document their procedures. We also are in charge of the change management process. The change requests are submitted by hospitals, as well by scientific associations of medical specialists. Our service desk is responsible for the intake and registrations, and our team evaluates these requests on content, terminology, and proposed mappings to other standards. And subsequently, the change requests are submitted for validations by experts from hospitals, the SNOMED NRC, WHO FIC, and the Scientific Associations of Medical Specialists. Now, approved changes are published quarterly by us, and the hospitals then update their systems with the new publications. Now, as Pim already told, the diagnosis DSORS is over 10 years in use by hospitals in the Netherlands. And we gather the data, medical and financial data, through the LBZ. That's the national database of the hospital care. And also the diagnosis source codes are submitted by the hospitals to the LBZ. Now, we have developed a dashboard to provide hospitals with insight into the coverage of the diagnosis registration using the diagnosis thesaurus compared to other similar hospitals. So you can see in the upper left corner a trend analysis, what the coverage is in this period from 2020 of 2019 to 2025. And it's also insights per specialty. So you can see what the coverage is of the diagnosis thesaurus registration for each specialty and what other hospitals are doing. Now, this submission of the DT has been made transparent per medical specialty, as I said, and this provides the hospital with the opportunity to engage in dialogue with the specialty and explore whether documentation and submission processes can be improved. The purpose of this monitoring tool is to offer hospitals and healthcare providers a feedback loop to improve source documentation and thereby enhancing data quality. Oh, this is the same slide. We also have made a viewer, and it's called the T-Rex viewer. And this viewer is publicly available. The viewer you can use this viewer to see what is available in the diagnosis thesaurus and the verrichting thesaurus. You can search by terms, keywords, or by codes. And you can see what terms and what DBC codes, what SNOMED, which SNOMED, and which ICD-10 is mapped to this interface term. On the right, we use the hierarchy of SNOMED to represent the diagnosis thesaurus in a browsable view. And this is what clinicians are really excited about, to search within the diagnosis thesaurus by hierarchy. Now, we have some challenges. We map the diagnosis thesaurus and the predictive thesaurus, the interface terms on SNOMED. But we have now in the Dutch extensions, it contains 15,000 unique SNOMED concepts. And that creates some difficulties for international research project, but also cross-border exchange in light of the EHDS, but also for care in the border regions.
Yeah.
I give you.
So 10 years of implementing the diagnosis thesaurus. So all hospitals use that one. So how many are there? 80, something like that. And the procedure thesaurus is used now by 19 hospitals. So how are we using SNOMED data? So there is a lot of SNOMED data already in your hospitals. Sometimes they even don't know that they have SNOMED data, actually. So we are organizing a so-called pizza sessions evening. I don't know if you know, but traditionally, if physicians have to fill in quality registries, they do it afterwards, too late. So they organize evenings, we call them BAMI or pizza evenings, to collect the data and get quality registers up to date again. And I think if you have the core medical data correctly, then the quality registers should be filled almost instantly. So pizza sessions, and it was about harvesting, but what's in it now for a SNOMED data? How is it used? So we talked with clinical business intelligence experts, quality advisors who ask questions about the quality of the healthcare provided in the hospitals, and clinical coders. So these three sessions already, and we'll have some more. And what comes out of it? Low SNOMED awareness. Sometimes they don't realize that SNOMED's already inside. For a BI, business intelligence, yeah, we heard about SNOMED, but we don't use it. We use ICD-10 because that's what the doctor asks for. So low SNOMED awareness. And yeah, that's a pity. Also the integration in data warehouse. Sometimes it's difficult to find SNOMED code, so you need a mapping table to get it out of it. So it's a threshold for BIs to use it. SNOMED has great power if you use the ECL tooling. But it's not inside the data warehouse, so we have to train people in using the ECLs tooling and then cut and paste the results out of that into normal query tooling. And then, so that's something which can be improved. And we saw with the clinical coders, they realize if we get better data at source, that will change their role, because clinical coding in the Netherlands, I don't know how it works in the other countries, after the discharge of the patient, then the clinical coders come in and they go through all the letters and results, and then they come up with the proper ICD-10 codes afterwards. Of course, we want to move that forward, but then you need other type of clinical coders, probably more data coaches. But they were quite critical, and also the people from the quality registries, the quality advisors, that the doctor is not documenting quite well. The quality of that's yeah. Despite that, yeah, you're laughing, so people recognize that there's scope for improvement. So the potential is recognized, but how can we really make benefit of it? So I have to come back to this slide, because I was looking after this weekend. I thought we see a lot of challenges. What we don't see is how people are using it anyway. Researchers are using it, young researchers are using it. I train clinical informaticians, and then they come up with a project and they use SNOMED. For them, it's just SNOMED. No need to mention it. It's just a good thing. So I didn't mention it here, but that's not a challenge. That's really what's happening already. Before what we saw in those pizza sessions, low-hanging fruit, I think, train BIs to use SNOMED data. They're sitting on gold, I think. Let's make use of it. Integrate SNOMED properly in the data warehouses, including the ECL tooling. And enhance the clinical user experience. So how can we have better data at the source, at the point of care. So we need a user interface that needs to change. And it brings me to the AI scribe story where I'm working on. AI scribes, now they I don't know if you worked with already, they can summarize in English, and more and more they can summarize in our language, the Dutch text. I think there are more than 20 companies working on that in the Netherlands, usually small companies, and Microsoft, but they don't yet in the Dutch language. They were overtaken by the small ones, but they can summarize. The next step for AI scribes will be that they recognize the structures inside. And the GPs, they use the subvelds as subjective, objective, evaluation, and plan. Those structures, if they recognize, that's the next level, I would say. And then, SNOMED. Can they recognize the SNOMED context in a proper context? That's another level. Now we use for the hospitals, for the clinicians, the diagnosis and the procedures to house the DT and the VT. That's the next level. So you have a diagnosis. Does it fit one-to-one to the DT, or you have to make an algorithm to make it fit? That's the next level. And it only ends when the doctors say, yeah, this is correct, and it ends up in the proper fields in the EHR. So then we have a good summary and discrete data where we can use all kind of things with. And I think it was mentioned also in other presentations, validation is key to everything here. Now a lot of hospitals are busy implementing pilots with AI scribes, I would say level 1 or 2. A lot of clinicians have to validate for each hospital, for each solution. So how can we make that more efficient nationally? And I heard this morning also, perhaps SNOMED can do a lot of that for level 3 and help. So we are aligning that with a national project called RIGHT to see how they can help getting knowledge out of the AI environment, AI community to validate all these steps. But every step has to be validated. It's quite complex. Because we're in healthcare, we're not making cars or something like that. Okay, I have one very easy suggestion to make for the SNOMED community, and that's this. Yeah, make people aware that SNOMED is inside or it's powered by SNOMED. I think, yeah, if you don't, yeah, the doctor knows ICD-10 doesn't know SNOMED. The vendors hardly ever, they start now to realize the power. So SNOMED can be very powerful. We should be more open about that. In summary, I think we spoke about the importance about the records and that SNOMED should be inside there. We use interface terminologies in the Netherlands for the diagnosis and the procedures. I don't know what's coming up next, but that's it. And it has a huge potential. But even if people use it, you have to help others especially for secondary use, to make it more benefits out of it, more added value. It's not that difficult, I think, but you have to do it. And the SNOMED powered button would be nice. So, if you want to know more about the Netherlands, tomorrow Marije will tell more about other sectors, about how they implement SNOMED. Marije is sitting there, so please go to her presentation tomorrow. But if you have questions now, we are happy to answer them.
Well, thank you, Pim. We will now begin the question period. As a reminder, if you are in the room, please use the microphone to ask your questions so everyone online can hear as well. So, any questions? We'll hear.
Hi, thank you very much for this insight in the Dutch health system and data gathering. I have one question about the AI tool that you were talking about to capture um, whatever's in the file into SNOMED codes. One of the problems that I'm faced with, I'm a coder, is that there's not much in the medical file that you can use. So translating text into codes is nice, but if you don't have text, then what are you going to code?
Yeah. Well, the project which we're running now is that the conversation from doctor with patient that is being recorded, transcribed, and summarized. So that's the part where what I was showing.
Okay, so you start from the talk between the doctor and the patient.
Yeah, but for me that's an interface question. It can also be typing, I think. And then you have to encourage that if he does it correctly, that a physician benefits from the work, and then comes in the other AI possibilities like clinical decision support. That can only work if you have good data.
Because my experience is the only thing that doctors hate even more than writing is validating. So I don't know, how can we get the doctors to validate?
Yeah. Yeah, the hesitation is that we have to organize that on a national level, I think. And that's part of a project I'm starting to work on right now. But first, people have to realize that you can have discrete data out of this, but we have to make some steps. A lot of people are already happy with the summary they make now. Those AI software, it helps them a lot, really. All the physicians I speak to, they say they are pretty good summaries. I can talk with the patients and I don't have to write. I heard about patients saying, "Doctor, why don't you write this down?" So, yeah, okay, that's a new world. So that's a step. Great. But now the next level should be getting discrete data out of it. Actionable data, which we can use, as you can see, in all other loops here in this image.
Thank you.
Any other question?
Must be more questions.
There's another hand.
Stefan.
Yeah, thanks. I have a specific question to the diagnosis. It's ROS. I just tried it out, the T-Rex interface, and it seems that you find a lot of terms, but then they are only linked to ICD-10. Is this right? And not to SNOMED? For just an example, small cell carcinoma of lung. Yeah.
Yes.
It goes to the right ICD code, but the ICD code is less specific. It's just malignant neoplasm of lung. And so the interesting thing would have that who codes this also gets the right SNOMED code.
Yeah, we do this in collaboration with NICTIS for the SNOMED, and NICTIS is the NNRC for the Netherlands. And for the ICD-10, we have ICD-10 experts working at DHD. And we also collaborate with WHO FIC. This is in the RIVM in the Netherlands. And they authorize and validate the ICD-10 mapping for each term.
And do you have a rough estimation of the effort it requires to maintain the CSRI, let's say, in full-time equivalence?
Now we have 10 colleagues full-time working on the diagnosis and verrichting thesaurus. We also do development for more secondary use cases. And we are full-time busy with maintaining the standards.
And I can add that with my previous experience as head of the National Release Center in the Netherlands, many years of work to collaborate with the DHT to maintain. And the more doctors are using it, they will ask for other diagnosis. Or now we are generalizing diagnosis. It's too specific. Sometimes we hear so. It will never stop, but the more they use, the more questions you will get, and then I expect that at a certain moment it will flatten out. You're smiling, but
Well, thank you, Pim. Thank you very much. Great experience. So